Great. Thank you, and good morning, and thank you for the invitation. Let's put up my disclaimer really quickly and get right to it. The Millennium Cohort Study itself has been ongoing since 2001 and was established as part of the 1999 NDAA, which directed the Secretary of Defense to establish a longitudinal study to look at health conditions among service members upon the return from deployment. And so this ultimately became, and this was also in part due to recommendations from the IOM back in the late 90s as well. And this, in a sense, has become the Millennium Cohort Study, which has the overarching objective of prospectively determining impacts of military deployments, experiences, and exposures on the long-term health of service members and veterans. And it is now the largest and longest-running cohort study in military history, with over 200,000 service members enrolled who represent all services and components. And this is really operationalized as a multi-panel cohort study of service members, and they've been enrolled over four enrollment panels between 2001 to 2011, and our participants complete surveys every 3 to 5 years that really encompass a wide range of mental and physical health outcomes, health behaviors, military exposures, and experiences, and we link as well to numerous military medical databases. This is illustrated here in this diagram that shows the panels as well as the survey waves. We do plan on launching the next follow-up survey later this year, and we do plan on enrolling our 5th panel, which is a bit delayed because we're waiting for the transition to DHA to make that possible. The total population of the cohort is currently at 201,000, and this illustrates the size of the panels, and also highlights the oversampling of certain groups, including women. The demographic profile of the cohort is illustrated here, as well as some military characteristics. And if you look at the lower left corner, you'll point out that because this study was started before the events of 9/11 and the subsequent military operations, we have a cohort where 65% have ever deployed, 71% are now separated from the military, and 1.2%, or about 24, a little more than 2,000, are now deceased. This illustrates some of the numerous databases that we have capabilities to link with, including military medical records. We have a new data use agreement with the VA to also link with VA medical records. So we're looking forward to incorporating that information into our research as well. With respect to respiratory outcomes, knowing that this is a very wide range health study, we do ask our participants on their surveys about physician-diagnosed conditions, including asthma, chronic bronchitis, and emphysema. At baseline, participants are asked if they have ever been diagnosed, while at follow-up, they are asked about diagnoses in the last 3 years. In addition to these diagnosed conditions, the participants are asked at each survey about persistent or recurring cough or shortness of breath. For participants' deployment histories, we link with the contingency tracking system maintained by DMDC to get the country of deployment as well as their in and out of theater dates. However, getting to within country locations, which is really critical for exposure assessment, is really not possible at this time because that data is classified. But we do anticipate this change in the future with the rollout of the individual longitudinal exposure record, the ILR. The first MILCO study on respiratory health and deployment status was published in 2009 and looked at respiratory outcomes from 2001 to 2006. And that study observed higher odds of self-reported new onset respiratory outcomes among deployers than among non-deployers serving the Army and the Marine Corps, as illustrated there. However, we didn't see associations with deployment for specific respiratory conditions such as asthma, chronic bronchitis, or emphysema. One important question that we do ask of our participants on their surveys is their exposure to combat during their deployments. And so this is ascertained based on deployment dates from the CTS, as well as a 5-item survey question shown here. And I do want to add that since the 2007 survey, we've also asked participants about combat using a 13-item measure, which allows for more granularity. We use this variable to examine its relationship with incident asthma in a study published last year. Here we observed elevated risks for asthma among deployers who experienced combat exposure, compared to those who did not deploy, as well as those who deployed but did not experience combat. This association, or adjusted association, was observed among both men and women. In addition to this work, we have previously looked at the association between deployment near burn pits and long-term respiratory health. For this analysis, we examined a population of Army and Air Force deployers with whom we had information from DMDC on their proximity within 3 miles of 3 documented burn pits in Iraq between 2003 and 2008. In the final report that was also published in the Journal of Occupational Environmental Medicine in 2012, we did not observe any associations with respiratory diagnoses or symptoms. But since that initial report, public concern about the long-term health effects of burn pits has increased, as indicated by both the IOM report and recent GAO reports that are listed here. In 2017, Health Affairs requested an updated MILCO analysis that would incorporate additional follow-up surveys that were administered in 2011 to 2012 and 2014 to 16. In this updated analysis, we extended follow-up for our Army and Air Force deployers through the 2014 to 16 survey cycle. For this total population, we only observed an elevated increase in respiratory symptoms among those who were deployed within 3 miles of a burn pit. However, and this speaks to one of the unique capabilities of the Millennium Cohort, when we stratified this population on their smoking status, looking at current smoking, former smoking, and never smoking, being near a burn pit, in this case 3 miles, was associated with elevated asthma risk among those who never smoked, but we didn't see this increase among former or current smokers. We also see this difference for respiratory symptoms. It's led us to speculate about whether never smokers have a greater vulnerability to burn pit smoke, while current and former smokers who have already experienced, the respiratory insult of tobacco smoke exposure would not be as susceptible to the effects of burn pit smoke. And so this is an analysis that was reported up to Health Affairs and presented at MHSRS, and we're currently working on that, getting that manuscript published as well. We do have some multiple projects underway at various stages of completion, and these include a study on deployment, mental health, and cardiovascular comorbidities and respiratory health that's being led by collaborators at USU with the manuscript currently in development. In addition, we have 2 studies underway that are looking at COPD with a particular focus on both OIF, OEF, and Gulf War I deployments. We're also conducting a descriptive analysis looking at post-deployment exertional dyspnea, and this analysis will be particularly focused on the change in ICD coding for shortness of breath, where ICD-9 had been very nonspecific, and ICD-10 has more codes available. And we also have a new effort looking at serum molecular indicators and burn pit exposure. This biomarker study is a collaboration with Dr. Arti Gautam from the Integrative Systems Biology program at RARE, and is supported by the Defense Health Program. And the objective of this specific study is to examine serum collected pre and post deployment. It's available at the DoD Serum Repository and was collected from those MILCO participants with known deployment proximity near the documented burn pits that I had previously mentioned. We will measure the sera for epigenetic changes in microRNA expression, as well as levels of metabolites of PAHs and dioxins and furans that are byproducts of incomplete combustion. We'll then look at these sera markers in relation to burn pit proximity, tobacco use, and other and adverse respiratory outcomes as well. And with this broad overview of our respiratory health portfolio, I do want to mention some important considerations, at least from our perspective. While we do rely on self-reported outcomes and the inherent strengths and knowing that there are inherent strengths and limitations of that data, we also do actively use military medical records in our analyses, including for sensitivity analyses. However, those data really only cover active duty personnel and activated reservists during their service time. We do, with our new data use agreement with the VA, we do expect and plan on linking also to VHA medical records. Because we also want to ascertain deployment locations beyond the country level, we are looking forward to the rollout of the ILR, as I previously mentioned. We also plan on focusing more on specific occupations with exposures to respiratory hazards. Certain occupations come to mind, including flight line personnel as well. And finally, I want to add that the next survey that we will launch later this year will include items on the frequency and severity of asthma symptoms, and in order to take a more granular look. And these questions will also be asked of our will be asked not just of our current participants in this current cycle, but in the new enrollment panel that we anticipate in the next couple of years. And with that, I'm happy to take your questions. Thank you.
Thank you. Questions for Dr. Rull?
With regard to the follow-up new diagnoses, are you precluded from going back to these people and asking them for permission to get to their primary care docs and get a documentation of their diagnosis?
That is something that we haven't considered previously. I think it would be complicated by one. I think the source of the source of that primary care, whether it's within the military health system, within the VA, or outside of that. I think that there's opportunity to explore that within DHA and VA records.
But if you went back to the individuals and got permission, I don't see why it would preclude sticking with the DOD or VA.
That's something that we can definitely explore. I think with considering setting up another sub-study that would target those participants who had indicated a prior diagnosis is something that we could do with and set up another study for that.
In your 2019, the study you're about to undertake with focusing on asthma, how large a study do you anticipate that being?
It's our current. The follow-up study pertains to our currently enrolled participants, who number a little over 200,000. So we would be requesting surveys from those participants. The next panel that we would like to enroll, our targeted enrollment is 100,000 participants, and our plan is to recruit from 500,000 current service members.
Thanks for that. That is exciting work that you're doing. How are you going to get at the occupations and the occupational exposures in this kind of future approach?
Yeah, that's been something that we've been really thinking about. Because we don't have that ability to really take very deep dives within our data, because as the purpose of the study is really to go broad but not very deep, and that's something that we look toward linking with the DOORS data within the DoD, which is that repository for occupational environmental health data, which we really just started to explore. What data is in there with in relation to occupational environmental exposures.
Yeah, thanks for that. I may have missed it. And the plan for the serum biomarker studies, how large a study was that going to be?
That study was we're looking to request consent from about 1,000 participants from that sub-study that I'd mentioned about the burn pit proximity, and identify those and request access to their longitudinal or to their pre and post deployment serum.
Thank you very much.
Thank you.